Although oral anticoagulation can effectively reduce the risk of AF-related ischemic stroke, around a quarter of patients have silent or asymptomatic AF, which can still cause this complication. Opportunistic screening for AF is currently recommended. However, whether systematic screening for AF can reduce the burden of ischemic stroke remains controversial. On the other hand, the experience and data on the use of smartphone-based wireless single-lead ECG, or Sl Ecg in short, in community screening for AF has been scarce and based on a relatively small number of subjects. Furthermore, there are only a few epidemiological studies on the prevalence and risk factors of AF in the Chinese population, and none of them were performed in Hong Kong. The purpose of this study was therefore to assess the feasibility of community screening for AF using Sl Ecg and to generate epidemiological data on the prevalence and risk factors of AF in Hong Kong. In the one-year period between May 1, 2014 to April 30, 2015, 13,122 Hong Kong citizens voluntarily participated in a territory-wide, community-based systematic AF screening program. Information on history and symptoms of AF and medical conditions were assessed by an interview questionnaire. Anthropometric measurements were taken. A Sl Ecg was performed with the AliveCore device. AF detected by Sl Ecg represented non-paroxysmal AF. The prevalence rate increased with age and was higher in men than women. AF detected by Sl Ecg or self-reported by participants represented non-paroxysmal and paroxysmal AF. The prevalence rate increased with age and was higher in men than women. These prevalence rates are compatible with those observed in some recent studies on the US and European populations, but much higher than those reported in studies on the Chinese population. Predictors of AF detected by Sl Ecg include age, weight, BMI, heart failure, stroke, valvular heart disease, and history of cardiothoracic surgery. Predictors of AF detected by Sl Ecg or self-reported by participants include age, height, heart failure, stroke, valvular heart disease, coronary artery disease, peripheral artery disease, hyperlipidemia, and history of cardiothoracic surgery. Of the 13,122 Sl Ecg, 56, that is 0.4%, were uninterpretable. 101 participants had newly diagnosed AF. That represented 42.2% of AF detected by Sl Ecg, or 0.8% of all participants. The number of participants with previously known AF was 1,010, and there was a 10% increase in the prevalence rate of AF with this screening program. Among the participants with newly diagnosed AF, 66 or 65.3% were asymptomatic. The Chetwa scores of participants with AF detected by Sl Ecg and newly diagnosed AF were both 3.1. Predictors of newly diagnosed AF include age, sex, weight, BMI, stroke, and valvular heart disease. The area under curves for age and weight were 0.768 and 0.548 respectively. When a cutoff age threshold of 60 or above was used, there was a 98% sensitivity and 29.2% specificity in detecting newly diagnosed AF. These are our conclusions. Community screening for AF with Sl Ecg was feasible, and it identified a significant proportion of citizens with newly diagnosed AF. The prevalence of AF in the Chinese population in Hong Kong was comparable with that of contemporary Western counterparts. Apart from age and sex, different anthropometric parameters and cardiovascular comorbid conditions were identified as independent predictors of AF.